Hello, good evening. A very pleasant day to one and all who are attending this webinar. So, at the outset, I would like to thank Bharat's Serum and Vaccines and also Dr. Yash Javeri for giving me this opportunity. These are unprecedented times. We have been talking and hearing only about the COVID-19 and the coronavirus for almost more than 2 months now. COVID-19, pregnancy and pueperium, what is the global guidance? So let us talk today about what changes are going to happen to the antenatal care of the women and how we are going to manage women who are pregnant with either suspected or with confirmed clinical case of COVID-19 disease. I am Dr. Priyanka Mehta from Apollo Women's Hospital, Chennai. I'm a consultant obstetrician. So we have understood now that the world is changing, the earth is healing, and we have to live in harmony. COVID-19, we know, is an emerging, rapidly evolving situation. Any guidance you look at, any kind of information we want, the first thing is that this is a new virus. We still have to know a lot about how this virus is causing the infection and what is the problem. We of course know that these are RNA viruses. This virus is a very hardy, strong virus. It can last for up to 72 hours to even up to 5 days on various surfaces. So all the important points about hand washing, about social distancing, cough hygiene, respiratory hygiene, we will have to follow all of that and also educate and sensitize our staff who work with us in the hospitals as well as our patients about the precautions to use. This infection spreads by respiratory droplets and also by direct contact. We know that the global mortality rate is almost 3.4%, but what we don't know because of the few cases and lack of good evidence is the mortality rate in the pregnant women. How are we going to manage the cases? So my agenda for today is set. I'm going to be talking about how are you going to treat suspected, possible or confirmed cases during pregnancy. What is going to be the antenatal care in the outpatient clinics? How am I going to do the assessment of the women in obstetrical triage? What is going to be the intrapartum management of women with suspected or confirmed COVID-19 and also the postpartum and the neonatal care? One thing that is clear and evident is the main aim now is to reduce the transmission of the COVID-19 to pregnant women as far as possible till we are ready with the safe vaccine so that we can give immunity to all the women. Provision of safe care to those who have suspected and confirmed COVID-19. So this is the guidance which was in April beginning from the FIGO, where we are being told that the clinical characteristics of patients who are pregnant with COVID-19, it is quite similar to the non-pregnant adults. Information on vertical transmission, however, is limited, and there is no evidence that pregnant women are more susceptible to get the infection. Similarly, severe morbidity and mortality, like we have seen previously with our experience with the SARS and the MERS and the H1N1 epidemics or endemics which keep happening, is not as evident in the pregnant women. However, the 17th April update on the RCOG guidance does say that even though pregnant women do not appear more likely to contract the infection than the general population, pregnancy itself alters the body's immune system and also the response to the infections. So occasionally there can be more severe symptoms. So we have to prepare for the worst. Emerging evidence now is suggesting that vertical transmission is probable because as we are seeing more number of cases, we are finding newborn babies who are also COVID positive, but there is also a possibility of a direct transmission to the babies. So most centers reflect now an evolving situation and most of the guidance is a living document. So we have to keep updating and keep finding out as to what is happening and what is the latest. The effect on the fetus. So like I told you, currently there is no data suggesting an increased risk of miscarriage or early pregnancy loss. So you would have a group of women who are in their early pregnancy. So we can reassure them that there is no data suggesting increased risk of miscarriage or early pregnancy loss in relation to the COVID-19. Similarly, you would have, even though the ART procedures and the IVF procedures are suspended for the time being, there are going to be spontaneous pregnancies. So you have to reassure women that there is no evidence currently that the virus is teratogenic. Iatrogenic birth that has been happening, or preterm birth that has been happening, basically is for maternal indications, although there is evidence in one case report of a possible spontaneous pre-labor preterm rupture of membranes. What evidence do we have? So there are few case reports which are coming up. Initially, we had something in January. We had a Lancet report about the Chinese women who had contracted the disease, and there all the births were by cesarean, but mother and babies did well. Then from Iran, we have a case report where there is a case of a maternal death and also intrauterine fetal death at 30 weeks of gestation. There have been few case reports where women with severe COVID at the time of birth, they have had respiratory problems and they have required ventilation and oxygenation. Similarly, from New York, there have been two case reports. One is about 43 women who were tested positive for COVID-19. But the good news is that 86% and above had mild infection, so they did well. 9% had severe and 5% had critical, which is the trend which is also in the general population. But it's a very small sample size. So for now, we cannot draw a very definitive conclusion. But these are the benchmarks by which we have to go forward. Around 200 women attending the maternity units for labor and birth over a 2-week period. Again, 15% of these women tested positive. And of these, 4 only had symptoms. So we are going to see a lot of asymptomatic women who are going to come into and need our help. CDC has said for a very long time now, cough, fever, shortness of breath, headache and anosmia are the symptoms which we have to look for. They have added 2 days back that even look for chills, muscle pain, severe body ache, myalgia, sore throat, and of course the new loss of taste or smell. So this is something we have to be alert about, as a number of cases of asymptomatic women are going to increase. So this is going to be the universal guidance like we follow for the other infectious diseases like retrovirus or hepatitis. You have to screen them at entrance because this is a respiratory pathogen, and we have to be careful that you're screening all women. Make sure that they come to hospital with only one attender, not more. And once they have coming into your hospital, there has to be a strict screening system for anyone who is entering the hospital, which includes a hand rub, and that is a non-touch technique. A temperature screening has to be done. It is better that the screening is also done for the attender who has come with them. The appointments should be given in a staggered way so that your outpatient clinic, the waiting area is not crowded. Seating arrangements have to be made in such a way that a social distancing is being maintained. Designated, where are we going to take care of the women? So in India, in most of the cities, there has been, the government has been working really hard. There is a list which has been given by the state governments of the hospitals which are designated tertiary care centers, the government medical colleges, private medical colleges, certain other hospitals have been designated so that we don't mix the populations. Any woman who is a suspect, a probable case, or a confirmed case, they are supposed to be managed in a negative pressure room, isolation room. Of course, it is recognized that in many centers, this negative pressure room could not be available. So then what do we do about that? I would tell you in the next slide. All attending medical staff should wear appropriate PPE. So appropriate PPE also, I will tell you, it varies depending on where you're seeing the patient, but at least a very basic, make sure that when you're seeing all patients, because now we have to suspect that COVID could be anyone and everyone could have the infection. So a proper face mask, a head cover, a face shield, and the hospital scrubs are important. If your negative pressure room is not available, then you have to isolate these women either in single rooms, and we've been told that it's better that these rooms don't have air conditioner, but they should have good ventilation. And if you don't have single rooms, then COVID positive women have to be grouped together. For transfer, you have to transfer any woman who is pregnant, who has come in, just be transferred either from the entrance to the ward, or you're transferring her to the operation theater or the labor room. Team should be wearing appropriate PPE and maintain a minimum distance of 2 meters or 6 feet. Again, practically, sometimes this may not happen. Treatment of suspected cases. General treatment is to maintain fluid and electrolyte balance. At time of admission, for most of our low-risk women, we don't do the renal function test and liver function test, but it would now be prudent that for all women who are getting admitted, we have their latest complete blood count, because we want to know the hemoglobin, the platelets, get a renal function, basic bun, creatinine, electrolytes done. Liver function test also needs to be done, because we don't know which of our women is going to contract the illness, and they may go in from mild, moderate to critical. Also, coagulation testing, PT, PTT, INR is mandatory. We should be doing that for our women who come into labor. Other inflammatory markers, if you are, because once you have someone who is a suspected case or an infected case, a multidisciplinary team, it is better that she is seen with an obstetrician, the NICU neonatology team, the virologist, the physician, infectious disease specialist, the intensivist. So the entire team has to be alerted about the admission. And inflammatory markers are ferritin, CRP, procalcitonin. These are to be done if indicated, depending on the condition of the mother. When she comes, an oxygen saturation, the pulse, blood pressure, all of these have to be recorded. ABG, again, if she has hypoxia, if you do a baseline value, it helps in further management of the mother. For the baby, we have to see what is the viability for your unit. If the mother is coming in less than period of viability, how are you going to counsel her? Most units are able to take care of babies of more than 26 to 28 weeks. Otherwise, you may have to shift the baby for a NICU to a higher center. So maintaining fluid electrolyte balance is very important. That is why when they come for admission, the importance of doing a bun, creatinine, electrolytes, because we don't routinely do these tests for all our pregnant women in the pre-COVID time. So we will have to change our practice and do those tests. Symptomatic treatment is important for pain relief. It is better to avoid NSAIDs like ibuprofen, because we have heard a lot of adverse reports by use of ibuprofen. So better to use a simple acetaminophen or paracetamol, control the temperature, and the basic surveillance has to be done by the team. In case we need antiviral treatment, so antiviral treatment, there has been in news many drugs, hydroxychloroquine, azithromycin, lopinavir, ritonavir, and the other drugs, because you are going to, once you are COVID positive, you are going to, as an obstetric unit, get the consultation from your physician, infectious disease physician, virologist, whoever is part of the team, and they will help you decide that. Also remember, not all fevers are COVID. So the other bacterial sepsis also has to be thought of. So whether you're going to do a blood culture, the urine culture for patient who is having fever should not be forgotten. So you have to do that also. Again, timely use of antibiotics is very important where there is evidence of a secondary bacterial infection. Fetal surveillance, like I told you, after 28 weeks, we need to be doing that. That could be a CTG in the labor room. That could be an ultrasound growth with Doppler. When the disease is severe and critical, she has to be managed in a isolation ICU, because then there could be a high maternal and perinatal mortality. Blood pressure monitoring has to be done, and that is done with the intensivist in your hospital. One important thing which we forget sometimes in ICU is pregnant mothers after 20-24 weeks need to be lying down in a left lateral position for oxygenation of the baby. Many times they are admitted in ICU. We have seen with our experience with H1N1 infection, once they are admitted into the ICU, they probably would need delivery. And then if she is not stable, we prefer to do a cesarean section mostly, and that is a medically indicated preterm delivery. So that you have to individualize case by case. She's in the ICU, she is in labor, you expedite delivery by rupture of membranes and she delivers, or there is no role in that point of time. Sometimes we may need to even do a crash category 1 cesarean section for the mother and for the baby. Oxygen therapy, again, it is important that you maintain the saturation to more than 95%. Another important point is the use of low molecular weight heparin in severe cases. So we may need to use a low molecular weight heparin in severe cases has to be considered. Some units have also been doing chest X-ray or CT chest screening because of the early appearance of the lung signs which happen because when we do these radiological tests. So there should not be a worry about the radiation exposure by doing a chest X-ray. That can be done, because when we do an X-ray, the maximum amount of radiation which goes to the fetus is 0.005 to 0.01 milligray, and for a CT it is up to 0.6. So up to 600, only when we go beyond 600 we have to worry about the fetal risks. But at this point of time we can safely do chest X-ray or a CT chest, because this could be a primary tool for detection of COVID in certain red zone areas where the cases are more. Informed consent should be obtained, and radiation shield is applied over the gravid uterus. So next is the number of clinic visits in the low risk women with uncomplicated pregnancy. When we are going to talk about antenatal care, women are pregnant in early pregnancy, mid pregnancy, they could be in the later half of pregnancy. So how many visits are recommended? So previously we used to have at least 13 to 14 visits, once every month up to 7 months. From 28 weeks, we will be calling them once every 2 weeks. If they have a high risk, then we call them even every 4 weeks and do a growth scan also. But now our care is going to definitely change, because the number of clinic visits in our low risk women, especially with uncomplicated pregnancy, it can be decreased, and we have to replace them with the virtual visits using phone or video calls. Women may be advised to check their blood pressure at home. Very important is we should not miss out women who are primigravidas, previous preeclampsia, or she has a GDM. So you have to make sure that the blood sugar monitoring they are doing at home. If your system is midwives, like in India, we have the ANMs, VHN, we have the ASHA workers. So these are the ground level workers, and there has been a lot of record taking. Data is there for all the pregnant women, all the births are registered. So there will be data of the women. So the women who are in different gestation age, immunization is done, the tetanus vaccine, all of that. So at that, for that women who are coming to the hospital, that can be done at home also. The ANMs, the VHNs, and also the telephonic consultations, video consultations are also being done, so that certain visits can be avoided. Of course, any woman who is going to come to the hospital, she should be sensitized that they should call the hospital before they come. And also, if they have a screen positive, which means if they have symptoms of the fever, cough, or chills, myalgia, then they can defer the visit by 14 days. If they have respiratory difficulty or the temperature is more than 100 degrees, then they need to come to the hospital. And then at that point of time, when they come to hospital, they are going to be seen in a separate screening area. So provisions has to be made by the obstetricians, by the healthcare providers. So whoever is coming to hospital, they have to undergo screening for temperature, and the healthcare worker who is doing the screening for temperature, who is seeing them at every point of time, should be wearing the PPE. Also wearing mask. Now there was a controversy about whether you should wear the mask or not. So wearing a mask is a good idea, because it is also depends on what mask you're wearing, but also you are not going to be touching your face and your nose and your mouth repeated number of times. So next I'm going to just talk to you about the antenatal. So this is what is usually, so this is the FIGO recommendation. We have been calling our women early pregnancy scan, and then at 12 weeks they come for a scan. So the early pregnancy, once the routine pregnancy test is positive, we have to sensitize them that first call can be with a video call or a telephonic call. Reassure them. They are very anxious, they are very nervous, so tell them that things will be fine, and she just has to be at home. She has to start the folic acid supplementation. In case they have nausea, they have to start the tablets which are usually given, like doxylamide. So all that can be given by a virtual prescription. And of course, nowadays people are having access through smartphones, and also different ways are there, or one of their attender can come and take the prescription. So you can avoid the very early pregnancy visit. The first visit they need to take is at 12 weeks, and that is a time when depending on your unit's protocol, you're going to offer them the first trimester screening. or the 12-week screening for the different aneuploidy conditions. Of course, you have to assess the risk factors at this point of time. If she has a previous high blood pressure, if she is diabetic, if she has any other medical problem, if she's obese. So thromboembolism, I will come to that a little later, again is a problem. You're going to tell your women they can't go out. There is lockdown all over the world. So there is a risk of increased venous thromboembolism for these mothers. So if they are having risk factors, you have to screen them for VTE. So you have somebody who is obese, who's a primary gravida, or you have a high risk for hypertension, you may need to advise them even for a low molecular heparin. So I will come to that soon. Educate women about COVID-19. What are the precautions? So you have to keep telling them again about the same washing hands, cough etiquette, and respiratory hygiene, social distancing. What are the symptoms for which they have to be worried about? What are the red flag symptoms, and how we are going to modify their antenatal schedule. 16 weeks is the next visit, which they used to come in person. So this can safely be done by phone or video. Another important thing in the early pregnancy is the flu vaccine, which was being given in many parts, and even the CDC recommends that the flu vaccine has to be given to the antenatal mothers, so that you can give very safely. Of course, tell them clearly that this vaccine is not going to prevent them to get this COVID-19, but this is because we are also seeing many H1N1 influenza-like illnesses, so pregnant women should be getting the flu vaccine. The TD vaccine, tetanus, diphtheria vaccine also, which we were giving usually in the early pregnancy, has to be given. 20 weeks is the next time when they come for the anatomy scan, and for that advise them as you do that they will come for these scans. So the appointments have to be given at a staggered time, so you don't have too many women coming in at the same time. The 24 weeks visit again could be a phone or a video consult, and that is when they also check either they do the glucose tolerance test as an outpatient or do it as a home care test. From 20 weeks onwards, make sure that women are checking their blood pressure, because this is something they check when they come to the hospital. So not only for high risk mothers, like a glucometer, thermometer, even a blood pressure machine nowadays, people can have that at home, because for now we want to reduce their visits. So it is advisable that they check their blood pressure at home. The 28 weeks, again, we are going to call them for ultrasound. And if she is rhesus negative, partner is all positive, then we are going to advise them for the anti-D vaccine. And for this, they are going to come in person. The growth scan, which is done, is as per your unit protocol. You may be doing it at 28 weeks, 32 or 34 weeks. The 30 weeks visit, the 34 weeks again could be a phone and video consult, and then onwards the 36 to the time of their EDD is going to be. So this is going to be in times to come. We have to plan their visits, routine care, unless there are specific concerns. Coming to fetal monitoring, as we know, new infection, it's a new virus. We still don't know what could be the adverse effects, but there is no evidence that there is fetal placental complications until more data is available. So closer monitoring is advisable. We may need to do a growth scan for those who are COVID positive in their early pregnancy. Obstetric triage, so you are screening for symptoms, as I told you, have your isolation or a separate private room ready. Patient and her one single attender who is asymptomatic should be wearing a mask and should be following the other hand hygiene. Evaluate and assess for other comorbidities. Women with mild symptoms, for now we are admitting all our mothers, but as a number of cases are going to increase, probably women with mild symptoms, no risk factors for severe disease, could be discharged home after being advised to monitor the symptoms and to seek care in case the symptoms worsen. Intrapartum care. So now you have somebody who is either suspect or she's COVID positive and she's coming into the hospital. So the COVID-19 infection per se would not be an indication to deliver. She could be 28 weeks, she could be 34 weeks, COVID positive, she's got the symptoms, you've admitted her, she's recovered, she goes home. But as unless she is either in a severe or critical state, and many times because the cardiac problems and the other problems for pregnancy sometimes come at this time of 30 to 32 weeks, we have to take a decision with the family and with the multidisciplinary team of the hospital and then decide for her delivery in case she's COVID positive and her condition is worsening. Delivery or the cesarean has to be in a negative pressure isolation room. So what we have done in our hospital is we have created a separate operation theater. The negative pressure one room which we have converted that into OT. So if they come in labor, we deliver them there, or we have things ready there so that the entire OT staff can be mobilized and we can be doing the cesarean for the COVID positive there. Separate hospitals, of course, have to be identified, but when someone comes into an emergency, uh, either in labor or they are having an obstetric emergency, then we cannot be transporting the patient. So there has to be a designated room. Important thing is birthing partners not to be permitted when the mother is COVID positive, or else they have to be wearing PP. So that is something you have to see in your, what is the unit protocol you are following. Number of staff members caring should be as low. So for a vaginal delivery, not more than 4 people. For a cesarean, 6. So you have the anesthetist, you have the anesthetist technician, operating surgeon, 1 staff, the neonatologist, and probably 1 assisting surgeon is the maximum you could allow for when you're doing a cesarean. And the mode of birth again should not be influenced by the presence of COVID-19 unless her condition demands an urgent intervention for birth. So I would come to that. Because we have seen vaginal secretions and so far the results are negative. There is also a question about regional anesthesia. Definitely, regional anesthesia is preferred, spinal or epidural. So someone who is coming in labor, we are going to, depending on what is available in our unit, epidural earlier is a good thing to do. Entonox is also used for pain relief. So we have to be kind to our mothers. We have to offer the routine pain relief for the mothers. Entonox by the RCOG has been told it's not an aerosol generating procedure, but you will have to see what filters you're going to be using for the Entonox, because you don't want to spread a lot of aerosol. Again, timing and mode of delivery has to be individualized, taking into account all the other risk factors, the clinical status of the mother, what is the gestational age she is at, and what is the fetal condition. Important thing to remember is we were a little confused a month back. How do we deliver? Most of the Chinese women who were delivered during the problem in Wuhan were delivered by cesarean section. But as a number of cases are increasing, we cannot be putting such a big load on our operation theaters. So vaginal delivery, someone coming in labor, progressing well, is not contraindicated. But we also have to have a low threshold to expedite the delivery, especially when there is a fetal distress, there is a poor progress. Because remember, in a pandemic, there is no emergency. So even if there is a crash, the healthcare professionals have to wear their appropriate PPE, which takes a good 10 minutes, 15 minutes time to don. So you have to be ready, and you have to have a low threshold for expediting the delivery in a fetal distress. So you cannot be giving long trials and like for a pelvic disproportion and all. And you have to also be really aware and alert as to the other obstetric emergencies. You could have an antepartum hemorrhage, a postpartum hemorrhage, shoulder dystocia. So all of those things have to be kept in mind in these situations. So again, each case, on a case-to-case basis, you have to see what is best for the parent, for the mother, for the baby, and also for the healthcare workers. So like I was telling you, in the Chinese case series, there was incidence of fetal distress, and most of them were delivered by the cesarean section. Again, if you have someone who is coming in full-blown sepsis with septic shock, or there is an acute organ failure, or there is a fetal distress, then you have to be going ahead with an emergency cesarean delivery. And that again has to be in an operating room with the negative pressure. So avoid, of course, what is a no-no totally is a birthing pools, water birth, because you have a risk of spreading the virus through the feces. Staff again should be having the PPE. Umbilical cord clamping intrapartum. The FIGO told us a month ago that you should be doing it promptly, but now the RCOG says, see, you have advantages of delayed cord clamping. You're going to reduce the postpartum hemorrhage. And if you're going to, the moment the baby delivers, you clean and wipe the baby. So you can have a delayed cord clamping, which is beneficial for the baby and also reduces the postpartum hemorrhage for the mother. transfer the neonate to the resuscitation area, and the pediatric team then takes care. And they also need to have the PPE. Again, make sure that you are assessing the VT risk. So RCOG says that it is prudent now that you're going to start the low molecular weight heparin. You're going to assess the maternal condition. When you have a COVID positive, it is advisable now that you start low molecular weight heparin. Prophylactic dose, at least you could give her enoxaparin, you could give her dalteparin once a day dose, because these mothers who are positive, as their condition worsens, sometimes they are also prone, in fact, to be getting different kind of pulmonary embolism or embolic phenomenon. Early observations are important. The golden hour, which we say the fourth stage of labor. So you have to include not only monitoring of the heart rate, the blood pressure, but also include respiratory rate and the oxygen saturation, something which has to be. So this would need a lot of manpower. You would have to again be making sure that you have cleaning all these devices. Young women who are fit women, they actually compensate well, and then suddenly they may just deteriorate. So it is important to keep that in mind. Signs of decompensation could be you're doing a saturation and then suddenly you have a respiratory rate which is increasing. So we are used to monitoring the mothers when we take care of someone who has preeclampsia on magnesium sulfate. So we do keep them on continuous pulse oximeter. But as the numbers increase, how many of the pulse oximeters are we going to have? How many staff are we going to have is going to be a question. Only time will tell us the answers. So reduction in urine output, respiratory rate of more than 30, or drowsiness. So all these things should alert us that this mother is probably going to get a little sick. Of course, you are allowed to perform the chest X-ray, and also the CT scan is advisable. Like I told you, I'm repeating again, all pregnant women who are admitted. So you have someone in early pregnancy or mid-pregnancy with COVID infection, mild or moderate or severe, you've admitted them, you should be starting them. They should receive prophylactic low molecular weight heparin unless you're going to expect the birth within 12 hours. So it is important that we also think about low molecular weight heparin when we admit them. And of course, passive leg exercises and the other TED stockings are recommended for the mothers. Anyone who is admitted who is pregnant, chest pain, worsening hypoxia, the first thing you should think of is pulmonary embolism. Don't think that this is nothing and you can just take care of it. Suspect. So prepare for the worst, anticipate the worst that can happen, and hope for the best. That is something you have to keep telling yourself till this pandemic is going to last. Breastfeeding, there are a lot of questions mothers want to know. If she's critically ill, of course you have to separate mother and baby, then she cannot be feeding. But mothers, and then you can be using the dedicated breast pump. Remember, that has to be thoroughly washed as per the manufacturer's recommendations. For mothers who are mildly affected, breastfeeding and rooming in is allowed. Of course, mother has to be again reminded again and again for repeated hand washing. She has to wash the breast, and she has to wear the mask, and make sure again cough etiquette. She should not be coughing in the hand. She has to be coughing in the elbow. Keep the baby's cot, baby separated by a curtain at least 2 meters or 6 feet away. Steroids, you have someone coming in preterm labor who is critically ill or who is having a moderate disease or even a mild disease. Giving steroid is with a lot of caution. You have to think about giving steroid, because we have seen with H1N1 sometimes their conditions worsen after the betamethasone. You're also then going to postpone her delivery by 24 hours. So a lot of caution has to be used for the use of steroid. Advisable not to postpone the delivery just for the sake of giving the steroid. Someone comes in with miscarriage, the embryo, the products of conception, the placenta, all of these are to be treated as infectious tissue like we do for retroviral or hepatitis positive, and they have to be disposed appropriately. As far as postpartum care is concerned, majority of the postpartum visits are to be conducted remotely once they get discharged by either video or phone. And this sometimes can be very creating a lot of anxiety for the mothers, because they are used, they come back with the baby, and they come show you the baby. They like to take pictures with the baby. They are so happy in the celebration. At this point of time, we have to be counseling them that postnatal visits, better to be did over video call or audio calls. If there are concerns, then they can share the videos and photos and that can be addressed. So this is again about the precaution that the mother has to take when she is feeding the baby. Important thing to remember is this is the time mothers could be very anxious. You have to also ask them about any kind of domestic violence. You are doing a video call with them as part of the antenatal or a postnatal consultation. Just ask them that if they are alone there, and then ask them the questions about domestic violence, because that also could be happening. Another thing is ultrasound. So when you have the ultrasound, and you have to also remember that ultrasound has to be cleaned. So the daily you have to clean it in the morning, and then you can in fact rinse the non-electronic contact with, rinse it with soap and running water, dry it with a cloth or a towel. Chemical wet disinfection has to be done with either glutaraldehyde or Cidex, hydrogen peroxide, the good old Lysol, Bacillol. All of these have to be used for cleaning of the ultrasound. So that is important, because with each patient you have to be doing this cleaning, and so you have to see how many appointments you're going to be giving. Ultrasound, first trimester, let them do the ultrasound at the 12 weeks only. If there is bleeding, abdominal pain, and you're suspecting ectopic, then only they will come for the scan. Again, anomaly scan is going to be at 20 weeks. Growth scan, if needed, that is for multiple pregnancy, or where you have a high risk mother, you're suspecting a growth restriction, then you would be probably doing the ultrasound 4 to 6 weeks. So these are the indication of these scans by the ISU-OG, that elective non-urgent IO 12 and 24 week scan, and the other growth scan. Whereas if a mother is having either a positive first trimester screening or a previous IU intrauterine demise, previous fetal growth restriction, then these are urgent scans. Emergency is whenever the mother is having any kind of vaginal bleeding. ART, again, there is no proof, and there has been very clear guidelines given by the ESHRE and the ASRM that the ART treatment and the any kind of IVF treatment for now is not safe. Only mothers who are undergoing, or only women who are undergoing fertility preservation surgery, the oocyte retrieval is advisable, but the embryos should be frozen to be transferred at a later date. Even elective gynecological surgeries, there is a high risk of mortality, almost 20%, so we can postpone by 6 to 8 weeks. Probably OTs would have to be equipped with all these smoke evacuation systems in times to come. So department should consider a lot of dry run stimulation exercises so that the staff are prepared, they are confident, and you can identify areas of concern to prepare for emergency transfer to the OT. Many places are going to be having shortages of masks. So these are one small methods by which you have this ordinary 3-ply surgical mask, and you can just make it kind of airproof. And these videos have been going around in social media. So I thought I can just share it, and you can just kind of close the bands on both the sides, fold it on both sides, and then this can be worn so that it kind of reduces the air entry on both sides. Again, there are cases where, if you see here, so this is one person who has made a used an OHP sheet and then use the mask, okay, a plastic sheet, so that can be then used as a facial sheet. So use a punch, and then you're going to punch in, and a practical method by which you can create and you can convert a simple mask. On the right side video, you can see somebody who is removing the N95 mask, either if she's going for a lunch or something like that, and just keep it there in designated mask. Once she finishes her lunch, she comes back, wears it without touching the front of the mask. So that's important. PP, again, this is the PP ideal which we should all be getting, but sometimes we just get this kind of PP. So just make sure that you have your goggles, you have a face shield which is there, and there is no part of the body which is exposed, so that you're going to prevent the viral load. Keep stickers like this in your hospital so that people are also aware, and they are also getting sensitized to the importance. So if everybody is wearing a mask, our reduction is this much. Again, make sure the staff workers, they are not reducing, they are removing their mask just like that, but using the proper technique. have, or these are the Government of India posters which you can stick all across your hospital. We are hoping for different institutes to come up with vaccines soon, and that is the hope. And this is probably going to be the new world with COVID, where we all would be wearing masks and shields so that we prevent infection. These are the guidance. I would also share my email ID, and any other questions, I would be happy to take the questions. Take home again is that you have to keep screening for symptoms, test, washing hands, physical distancing has to be maintained. Breastfeeding can be allowed with mask and care. All may not be gloomy. There is good news which is coming in. 80% and more of our women may recover, but like I say, prepare for the worst that can happen, but hope for the best. Thank you all, and thank you again to Bharat Serum and for giving me this opportunity. And thank you also to my co-moderators. Thanks again to all the participants from different places all across the globe, and hope that all of you stay safe and stay connected.